A significant proportion of patients will relapse following an allogeneic stem cell transplant, and unfortunately the prognosis for many of those patients is poor. So we're talking about 30 to 40% of patients relapsing after transplant. And I think in order to prevent that, we need to understand better the kinetics of disease post-transplant. I don't think we're there yet in terms of identifying exactly who will best benefit from some sort of intervention. Certainly, higher risk patients, you would anticipate that those patients are still, we know that from the data regarding the outcomes following transplantation using at least the IPSSR, that the prognostic significance of that is retained post-transplant. So those patients with poor risk disease will also relapse after a transplant. So to some extent, you can start to stratify those patients and understand who may be more at risk. At the moment, we use surrogate markers such as chimerism and declining chimerism to try to understand who may relapse and then intervene with preemptive donor lymphocyte infusion. And we are waiting for the results of the PRO-DLI clinical trial, which will give us some insights into the use of preemptive and prophylactic DLI to try and prevent relapse. So I think there's some interesting data to come out of that study. Similarly, in terms of the use of oral Azacitidine, the Amadeus clinical trial has almost, if not completed, recruitment. And this is a study that was randomizing patients to oral Azacitidine maintenance versus placebo post-transplant in a bid to try and prevent relapse. So I think we're waiting to see what happens with that study and what the readouts are. There are other interesting studies and propositions around the use, particularly we know that particularly high-risk transplant patients can be found within the TP53 mutated cohort, particularly the biallelic or multi-hit patients who are pretty much destined to relapse post-transplant and in some cases might be excluded by some centres from transplant because of the significantly poor outlook. And for those patients, we're seeing good signals with agents such as Magrolimab, and there's been a nice study published in JCO last year, which looked at the use of APR or Eprenetapopt to prevent relapse of TP53 mutated disease. And so there is some signal that perhaps a targeted approach, particularly for these ultra-high-risk patients, could be of benefit. When patients do relapse, I think this is a difficult scenario. We have presented in one of our abstracts just this morning about the data on the use of Venetoclax and Azacitidine for relapse in the context of MDS and AML relapse post-transplant. And the majority of that cohort was an AML-based population. However, there were some MDS patients in that group. And it's possible to salvage some patients using Venetoclax and Azacitidine even after a transplant and potentially bridge them to further cellular therapy in the form of a stem cell transplant or donor lymphocyte infusion. But I think going forward with relapse, and we know that those patients who relapse within 6 months post-transplant will have the worst outlook. Those patients who relapse beyond 6 to 12 months will have a better outcome. And certainly beyond 12 months, the aim would be to regain remission and then ideally move towards donor lymphocyte infusion or stem cell transplant as they would be eligible for second stem cell transplant. But I think what we need to understand is what are the drugs of choice. At the moment, many people will, for relapsed MDS, receive perhaps a combination of Azacitidine and DLI, and there's good data surrounding the use of that. But going forwards, I think perhaps how can we improve on those outcomes and get more people into remission and then consolidate them with some further form of cellular therapy.